the speakers to the panel, and then we'll start with a few questions, open it up to the committee, and then I think per our rules here to the rest of the members of the conference this morning. So I'm going to use the moderator's prerogative here to throw, at least I hope there's a moderator's prerogative, to throw out the first question, and I think I'll go ahead and ask Dr. Rathmel to expand on some comments that he made and some themes that he introduced. As a fellow clinician, it's confused me, and I'd like your opinion on whether, with the increased scrutiny on opioids, which certainly makes us think twice about initiating a prescription and maybe 2 or 3 times more about escalating a prescription, whether we have adequate substitutes for those drugs available to us as we try to provide good care for the patient, whether it be alternative or surgical or interventional. How are we going to address with alternative therapies what we might now have more difficulty using, the opioids themselves?
So it's absolutely horrible, right? I've been in the business now 25 years, and I sit before my patients, and I don't know if anybody should be on opioids. Should they? Is that a good long-term therapy? And we've seen the bad part of it. So we don't have adequate alternatives, and you and I know that we often march through everything we can think of and then a couple of things beyond what we initially could think of, and we're back to the opioid question. So should we be getting to the end of the non-opioids, and then everybody gets a trial of opioids, no matter how high risk, and we just try to manage them? Or do we just say opioids aren't the answer for anybody? And I don't know the answer to that. And I've taken care of a lot of patients over a long period of time. So the answer to your question is we don't have adequate treatments for a large group of patients. And what keeps all of us coming back to the pain clinic is that every once in a while we have a tremendous success. And so we keep searching. And for the others, we're there for them, that we help them over time. But sometimes I think the best intervention that I give is just seeing them. I'm there and I see them regularly, and I can look back over 10 or 15 or 20 years and say, I don't think they're any different than when they first came in, because we don't have adequate treatments.
Go ahead. Thanks a lot for those presentations. Can you hear me? Yeah. So I guess a lot of the issues you brought up seem to me to be kind of time immemorial kind of issues that we're always kind of struggling with. And I was wondering if each of you could highlight specific things that you think have changed, if anything, in the last 5 years. Like what has come recently that has helped contribute to the that's my question. Just sort of focusing on anything that's sort of just new.
So I would say that broadening this, recognizing the magnitude of the problem and getting providers to talk to one another has gotten much better. We can no longer go on in isolation. So the idea that we have collaborative care and that I talk to my primary care colleagues or I talk to my addiction medicine colleagues and they completely understand the problem and work together with me has gotten much better. But it's really hard care to deliver in 10-minute intervals, right? That coordination of care. So to me, that's what the big hope is. And there are little things, there are little things where we know the disease better and we can just zap right at it, yes. There are areas where, I can take care of that. Subacute back pain, I can help those people. I feel very good about it. And we know how to deliver that care. But in the broader context, it's the collaborative care that I think is what's gotten much better.
Yeah, just to follow up on that, I think there's a recognition there's a need for an integrative approach to pain management. It's not one size fits all. And I think, I've only been at I was at NIDA for 20 years, 19 years anyway, and moved to NCCIH for the last 3. And, I've been at NIH a long time, and just the word alternative, you're seeing a change in the words we use. It's no longer alternative medicine, it's integrative and complementary. And I think the umbrella for what's effective treatment is growing in the sense that it may not just be the medical model of a prescription drug, but there may be a more integrative way to approach this problem. It's also the case that I've seen over time is that there's an outcry from patients, that story about the retired school administrator. The Veterans Administration is hearing from their patient population that opiate medications are not, the medications in general are not working. People are feeling they can't cope with the medication. There's severe adverse effects. Of course, the overdose rate within the VA is quite high. So I think there's a recognition, too, from the patients that what the treatment they're getting is not working, and they're seeking other ways of managing their pain. And this is really an opportunity for us to think broadly, engage the patient, and think broadly about an integrative pain management that, medication may be one component, but we need to really think more broadly and how to integrate those treatments into primary care or medical healthcare settings in general. And I think that's where certainly NCCIH is making its a focus on that issue.
Yeah, I guess my response was is my mic working? Yeah, it's hard to look too much at what wonderful things happened in the last 5 years because we're still in an opiate abuse epidemic. We still have all these people in chronic pain. But what I've seen from the inside, at least with the government, there's a lot of spirit of cooperation. It's not, and even bipartisan support for doing something about at least the opioid problem. But I think there's also growing recognition that we have to take care of people in pain also. So I think to fight these problems, we have to work together, and I think there is the sense of doing that. But now we have to kind of shift both epidemics and start to see results.
I'm going to remind the people asking questions to state any relevant affiliation before their questions. So I think we'll go here and then across.
I'm Jose Moron, I'm a member of the committee, and I would like to make a question based on what Dr. Rathmel and Dr. Thomas talk about lack of education for pain management. So we know the majority of prescriptions filled for pain are given by primary care physicians, and when we look at the time that is devoted to pain management in U.S. medical schools, I mean, it's like I was looking the other day, some medical schools devote only 10 or 12 hours of education for pain management. So I would like then to comment on that and see how we can deal with this issue.
Yeah, sure. So David and I worked together on the education part of this, and we did map out a strategy for that in the National Pain Strategy. But I can tell you from the board, from the American Board of Anesthesiology and the Accreditation Council for Graduate Medical Education, the ACGME, that oversees training programs, I've spent a lot of time on this, and the question is, pain medicine as a subspecialty of anesthesiology really focuses on intervention. Should it be broadened? And I think all of us, even those of us who are real-life practicing anesthesiologists, recognize that interventions are a smaller part of the comprehensive care. So our centers, even anesthesiology-based centers, are moving away from intervention. The question is, what comes next? Should pain become a primary specialty? You come out of medical school and go into it? Or should it become a subspecialty of one of the primary care disciplines? I can tell you the leaders, we convened all of the leaders last year of the primary care disciplines, internal medicine, family practice, surgery, and said, should it become a primary discipline, or should we help you to make a fellowship? Those of us who are training pain clinicians help you make a fellowship. And there's no interest at the leadership level in primary care. And there's one fellowship in the United States in primary care that's gone unfilled. So primary care physicians don't want to specialize in pain. There's the minority. There are some, and there's some that we know very, very well that do a fantastic job. But that's the problem. Who wants to take care of these patients, and what should we do to get from where we are today, training 1 year after anesthesiology residency, or neurology residency, or physical medicine and rehabilitation, to the future state? And then I'll help you map it out. But nobody is stepping forward. We've got the status quo, and it's not serving our patients very well. So we need to revolutionize the education of pain clinicians.
And let me just add, that's very good comments. we can't just solve the problem by solving part of the problem. I mean, you need to get reimbursed, and you need to have it in the boards and part of accreditation. It's got to be the whole package. You got to go from every angle. We're working on the education part more with our centers, but the National Pain Strategy is taking it from all angles, and because you need to do all the things have to happen together to really change how pain is treated.
Hi, Penny Cowan, American Chronic Pain Association. Thank you all for your presentations. I think they were all really good and they brought out a lot of good points. The one thing that I thought was missing, though, is I didn't hear any of you talk about how we empower that person with pain. I didn't hear anything about self-management and giving them some of the responsibility. And I think until we change that expectation that you're going to take care of us and put some of that responsibility back onto them. So I was just wondering what your thoughts were on that.
Yeah, let me just throw it in. That was part of the, I'm sure you know, as part of the National Pain Strategy is public education and patient education and trying to make them part of the solution. And I think, as opposed to just go to a healthcare provider and you tell me what to do, and they should not only be part of the process, they should be empowered in a way to expect to be treated well. Too many times, pain patients are just, well, they feel like maybe I shouldn't complain, maybe I am being bad by, maybe the doctor knows best, but you should insist. I mean, and that's the message in the National Pain Strategy, that you should be part of the process, and you should not go away in pain and unhappy.
I would just say bravo. I mean, it's an unbelievably central component to this, and that's the way we should, when I sit down with my patients every day, I'm just an enabler. But convincing them that they have ownership is part of the struggle as well. But it's central. You cannot do it without your patients' buy-in and collaboration. It's a collaborative care.
I think it is starting that dialogue, and I referred to the Mayo proceedings, which really was, which we published just a few months ago, looking at the evidence for complementary integrative health for pain. And that was really designed for primary care physicians to have a conversation, and patients to have a conversation, and provide them with evidence-based information to have that conversation. So they have not only a dialogue, but they have some basis for that dialogue in science-based evidence about what works and what doesn't. So it really is the educating, and for us, it's educating not only physicians or healthcare providers within our institute, but one of our main missions is to educate the public about how to use and how to ask questions about complementary and integrative health approaches for a variety of symptoms, including pain.
And I add one more comment, that the committee has been provided some information on self-management as the core of much of treatment. So the concept that you're introducing is not at all going under the radar for us. So thank you.
And I got to make another comment, sorry, but there's the self-management part, but there's also the empowerment of pain patients. And we talk about that cultural shift. How do you shift the culture? Well, one way is if you get 100 million people saying we're fed up with this, that would have some impact. I mean, it's not going to realistically happen in unison like that, but to get the greater public engaged is something that I think could help change the system.
Okay, here, please.
My name is Rick Dart, and I wanted to bring up an issue that from our institution. I'm speaking this afternoon about surveillance, but I come from an inner-city hospital, Denver Health in Denver, and what we're seeing it was, I think, provoked a lot by the CDC guidelines, but it actually was starting before that, is that primary care physicians don't really want to treat pain, as I think you mentioned. I agree with most of the comments, frankly, but the ultimate result, people accuse me of being a doctor basher, but is that we chicken out and run away from the problem, and what we're doing is scaring the primary care providers into saying, I'm just not going to do this, I won't do it at all. And that's a real problem for us because we're poor and we don't have a pain service even. So when we get that kind of pushback, then it makes it so patients don't get much treatment at all. I want to make one factual point, though, is I wanted to clarify this issue about deaths from prescription opioids, because that is what my research is. And if you look at the NVSS data, it's not really true that prescription opioid deaths are increasing. When you look at the different categories, the methadone's going down, the natural and semi-synthetic are flat, maybe down a little bit. What's really going up is fentanyl, but that's illicit fentanyl. And when you talk to NVSS, they freely admit that they know that's illicit, but they can't be sure which cases, so they end up putting it in prescription even though it's not. And it's a subtle but I think important point in some ways, because we need to understand that we have made actually good progress. We have a paper in the New England Journal from last year showing that. And so it's disheartening to have people use that as a rationale, because I think it provokes us to more concern. We should be concerned. There's still way too much, but we're really shifting into different types of problems now. So thank you.
Comments from the committee on? Howard?
Hi, yeah. So this is for Jim and David. I've heard that it's becoming increasingly difficult to get third-party payers to reimburse for the type of multidisciplinary care that would be required for a typical patient that's exhausted all other forms of treatment. If that's true, that's a barrier, and it's kind of right in the way of what everybody's recommending we should do, which is comprehensive evaluation and multidisciplinary care. Is that true? Has that been your experience?
Well, we've had some conversations. This is really a question for CMS, Center for Medicare and Medicaid Services, but we've started to have some preliminary conversations with CMS on this very issue, and they understand that there is a need, at least the people I've spoken with there is a need to think about how to reimburse for these more integrative practices. How that will play out within CMS is, I don't know if the panel is bringing anyone in from that organization, but I think that's the type of question they would need to answer. What are the barriers that they're seeing in terms of reimbursement? And of course, every state is different, and then there's, of course, the insurance, independent private insurance providers that have different criteria for what's reimbursable and what isn't. And certainly this is well beyond what we do at NIH, so it even gets more complicated, at least from the NIH perspective.
So you've probably, Howard, this has gone full circle in your career. 30 years ago, we had meta-analyses that showed that the inpatient chronic pain programs that were functional restoration based were successful. Better return to work, sustained reduction in pain, better function, and reduced opioid intake. But they were too expensive, and insurers stopped paying for them and started paying for piecemeal things like interventions, right? So the outlay on interventions has gone way up, and we're not doing any better 30 years later. So I think, my belief is that this is calling for population health management. This is chronic disease management and collaborative care where different experts have to work together and share the pie. So per person that's labeled as chronic intractable pain, a group has to care for them and get paid periodically to care for them, whatever you decide to do, not based on the intervention you do. So it doesn't drive the intervention, it drives good care. How do we implement it? It's piecemeal. And we use interventions to pay for psychologists and alternative healthcare practitioners. I mean, you cross-subsidize. That's the way you do it, because we need all the pieces. And it's the problem, though, is out in the community, the people that don't want to take any of the reimbursement from the interventions and cross-subsidize don't offer it. They just offer the interventions. And that's a recipe for fragmented, unsuccessful care.
And Howard, one point, you probably should specify which David. I just realized that there's three of us. But I'm like, is that me? But part of what we can do with the tools we have is to fund research looking at comprehensive pain treatment, integrative things, and will it work better? And then within some contexts, we'll look at the application of that within some systems, usually closed systems, because they have more possibility of gaining from it, and see if it actually reduces pain and saves costs. But for other providers, it's hard to get them to do it, and that's going to be our challenge. But and it's I mean, this is like a catchphrase or something, but we're paying a big price for it by not doing it. So somehow the equation's got to get changed, and I don't know who's got to pay for it, but we're paying a price in terms of the IOM report, in terms of dollars amount for our country, but also in terms of human suffering. So somehow this has got to get done, and we're trying to encourage it every way we can.
I'm here primarily to listen, but since I do work in a large managed care system, the VA system, the dynamics are different, and I can assure you there is greater openness to the idea of using integrated health clinics, multidisciplinary clinics, any new title, because the question is how do you divide your pie, not how much pie can you get from the outside. So I think we have time for a couple more quick questions, maybe here and then here, and I promise we'll get to you.
Thank you. My question is it's about that. What I'm beginning to see is a growing treatment of using ketamine infusions, and wonder if you might comment on that, particularly in terms of anesthesiologists who are administering these for patients who come in with chronic pain. They've tried everything, and last resort they say, let's try this ketamine infusion. And we're getting 5-10 patients a day seeking this type of intervention.
Well, I mean, so it's just calling on that same issue of short-term analgesics for long-term problems, and they do provide immediate pain relief. There's scant evidence that they have some effect in the long term, but it's desperate measures for desperate patients, and it's, again, we're paying for the intervention. So it's something that is being done increasingly because the reimbursement's there for it, but is that going to be better than integrative care where maybe you do ketamine infusion in combination with longer-term strategies for self-management? You know, I think it's just one tool, and the evidence is not fantastic for any long-term benefit from that approach, but it certainly provides analgesia in the short term.
Again, I'm here primarily to listen, but I do, I think I would take the issue more broadly, Jim, and say that we're looking for treatments that are sustainable. I think that is part of the interest of the group, and considering which would really fill that bill, and they do have to be measured against each other, I think. One more here, and then I'm going to ask Morgan if we could, do we have until 9:55, or, because I see 20 minutes here on the total. Okay, so we do have time for a couple more questions. Go ahead.
Hey, John Calkins, Carnegie Mellon, and the committee. Great talks, very U.S.-centric. What would we learn from other countries that have strong healthcare systems? What's Germany's national pain strategy? How does Japan handle medical education in this area? And so I wonder if you could comment on some of those international differences or perspectives.
That's a good question. I can give you a little bit of information on that. Going back to that Mayo proceedings that I mentioned, we excluded, we only looked at U.S.-based healthcare studies because, for example, in Europe and Germany, integrative care is delivered differently. For example, physicians are trained in acupuncture, and physicians give, primary care physicians in Germany give acupuncture as part of standard of care, whereas here it's a specialty that needs to be outsourced and done differently. So the sense that when we took a concerted effort and conscious effort when we produced that proceedings, we focused on what was actually happening within the United States. But I think your point's well taken. We can learn a lot about how other countries are integrating healthcare, and certainly the European system may be a good place to look.
So I go all over the world and have seen a lot of pain clinics in a lot of parts of the world. There are a lot of different trends that are going on. So the fondness for interventional pain has skyrocketed in a lot of other countries. I've seen very heavily interventional clinics in China and Korea, all through Europe and the Middle East. So there's a fondness for being able to do something to people, right? So, but the other trend is there's a number of places around the world that really get it, particularly in the Netherlands. The Dutch federal system says, we understand this has to be integrated. We're going to put everybody in the same place. We're going to go back 30 years and get all the practitioners in one place so they can work together and collaborate. And we're going to have an emphasis on functional restoration. And that's where I've seen things supported by the one healthcare system at the local level, and they're funded. They're centers funded for providing care. They're not funded for doing things or any particular intervention. And they do interventions and they balance it with non-interventional and complementary alternative integrated healthcare. It's done very, very well. So I think the hints are there. We know how to do it. How to get the U.S. healthcare system to pay for it is a different battle altogether.
Hi, Chris Beasley with the Chronic Pain Research Alliance. Thank you all for your presentations. Dr. Rathmel, thanks for pointing out, the research, because I would agree with Dr. Thomas that the reason why we are in what we're in is not only because of the under-treatment of pain, but the gross under-investment in pain research. And if for the past few decades we would have been properly investing in basic translational and clinical pain research, we probably wouldn't be where we are. Dr. Shurtleff, just one comment. One of the decisional dilemmas that patients face around integrative care is not only access, but it's the multiple modalities within each of these. There's, dozens of types of chiropractic care. There's different acupuncture techniques and modalities. This goes on for almost every integrative option that's out there. And I'm wondering, from a research perspective, what NIH is doing to standardize these types of, integrative treatments, so that we not only know, should we try acupuncture, should we make a decision between physical therapy or Tai Chi, but what types of modalities or what standardization underneath each of these is effective?
No, it's a great question. If it make it even more complicated, each state has a different licensing procedure for each specialty, so it even gets more complicated. In terms of the research, what we're trying to really do is look at common factors across many of these modalities. When you think of Tai Chi, for example, it's really a movement, contemplative, meditative practice, and there are many other practices, including yoga, that have similar sort of at least conceptual frameworks. So what we're trying to really do is drill down to what are those active ingredients. And it may not be that across the different flavors of Tai Chi or yoga there's much of a difference, but rather the fundamental approach to movement and how those practices are done, the focus on meditative, contemplative practice that, for lack of a better term, calms the mind, increases top-down process to modulate emotion and sensation, may be the critical elements. And there may be non-traditional practices that can do the same thing, not just what's come out of the traditional Chinese medicine and other traditional approaches, but it may be these common elements that are important. For example, we have a study that was done several years ago that compared yoga to a rigorous stretching exercise for, I think it was for chronic pain, back pain patients. And in fact, both treatments were equally as effective. And this is where it gets back to a comment I think David made: what treatments for whom and under what conditions? Pain is complicated. From the most global to fibromyalgia to discrete pain. Subpopulations may respond to different approaches than others. These are research questions that I agree with you, with more time and more resources, we could really drill down and understand what is effective, why it's effective, and for whom. And that's still a question we're struggling with, but I think in the last 5 years, just to put a positive spin on it, I think we've made some progress here. The fact that our NLM Medline Plus magazine is highlighting Tai Chi, I don't think that would have happened 20 years ago. I think integrative complementary health approaches are being more accepted by the public and by the medical profession, and you're seeing it at the NIH.
I think we're just about perfect on time, so with that, we'll conclude the first session. Thank you so much for your questions and your attendance.